Hi guys, we are going through new subject called deep vein thrombosis. It is very important topic, and especially in patients which are hospitalized and have increased risk of deep vein thrombosis. So deep vein thrombosis, or DVT, is a blood clot that forms within the deep veins, usually of the leg, but also could be on the arms or in the arms, and the mesenteric and cerebral veins, very rarely of course, and represents the third most common cause of death from CVS or cardiovascular diseases and heart attacks and stroke. Deep vein thrombosis is an obstructive disease with hindering venous reflux mechanism, and it involves the lower limb venous system with clot formation originating in a deep calf vein and propagating proximally and obstructing the lumen of the vessel. The rate of particular site involvement depends on the anatomical location as follows. So deep veins 40%, popliteal 16%, femoral 20%, and common femoral vein 20%, and iliac veins 4%. Incidence and prevalence of deep vein thrombosis and pulmonary emboli are common and often silent, and thus go undiagnosed or are only picked up at autopsy. So even can be passed and nobody discovers this during the hospital stay or during the attack of embolization from deep vein thrombi. And therefore the incidence and prevalence are often underestimated. Annual incidence of DVT is 80 cases per 100,000, with a prevalence of lower limb DVT of 1 case per 1,000 of population. This data is from United States, of course, and it means that more than 200,000 people develop venous thrombosis. Of those, 50,000 cases are complicated by pulmonary embolism. In the US, is evidence of an increased incidence of DVT and an increased risk of complications, especially in African Americans and white people when comparing with Hispanics or Asians. Associated diseases. So in the hospital, the most commonly associated conditions are malignancy, congestive heart failure, obstructive airway disease, and patients who undergo surgery. And as long patients staying in hospital, the risk of deep vein thrombosis increases. Let us discuss risk factors. So reduced blood flow, increased venous pressure, mechanical injury of the vein, and increased blood viscosity. Reduced blood flow from immobility, so patients staying at bed rest, or patient is under general anesthesia with a long time period, operations, stroke, and long flights. Long flights mean more than 8 hours, or like this. Increased venous pressure, like mechanical compression on, or a functional impairment that lead to reduced blood flow in the veins, like pregnancy, neoplasm, stenosis, congenital anomaly which increases outflow resistance. Mechanical injury of the vein, like trauma, surgery, peripherally inserted venous catheters, especially catheters which are central venous catheters, history of previous DVT or deep vein thrombosis, and intravenous drug abuse. And increased blood viscosity from polycythemia vera or rubra, thrombocytosis, and dehydration, which make concentration of the blood components, which lead to agglutination and formation of thrombi. And anatomic variations in venous anatomy can contribute to thrombosis as well. Here we have increased risk of coagulation from the following. Genetic deficiencies like anticoagulation proteins C and S, antithrombin 3 deficiency, factor 5 or Leiden mutation, acquired one like cancer, sepsis, myocardial infarction, heart failure, vasculitis, systemic lupus erythematosus and lupus anticoagulant, inflammatory bowel disease, nephrotic syndrome, Barnes oral estrogens, administration or oral contraceptives, smoking, hypertension, and diabetes. Of course, most of these risk factors affect vessels and especially inflammation and produce procoagulation. Constitutional factors like obesity, pregnancy, the advanced age of older than 60 years old, surgery, critical care admission, dehydration, and cancer are established causalities of deep vein thrombosis and venous thromboemboli. Obesity is associated with hypercoagulability status via two mechanisms like increased fibrinogen levels and slower venous circulation flow in the infradiaphragmatic and especially in the lower limbs. Potential risk factors of deep vein thrombosis might be categorized according to the periods like transient, persistent, or unprovoked. Accordingly, transient risk factors are as follows, like surgery with general anesthetics or general anesthesia, hospitalization, cesarean section, hormone replacement therapy, pregnancy and peripartum period, lower extremity injury with limited mobility for more than 72 hours. And this limitation of movement for more than 72 hours should be accompanied with administration of anticoagulants, indirect one. It should be noted that general anesthesia for longer than 30 minutes and hospitalization for longer than 72 hours or 3 days is considered the transient risk factors are considered the transient risk factors for deep vein thrombosis. Active cancers and specific medical conditions that increase the risk of venous thromboembolism are categorized as persistent risk factors. And inflammatory systemic diseases like systemic lupus erythematosus, inflammatory bowel disease are among the predisposing medical conditions. Recent studies evaluating the association of blood lipid levels and lower extremity deep vein thrombosis demonstrated that higher total cholesterol levels, high density lipoprotein, and apolipoproteins were associated with a decreased risk of lower extremity deep vein thrombosis. However, high triglyceride levels were associated with greater risk of lower extremity deep vein thrombosis. Let's move on pathophysiology, and according to Virchow's triad, the following are the main pathophysiological mechanisms, like damage to the vessel wall with inflammation, blood flow turbulence. It's about a flow that is not laminar or going easily without any obstacles, and hypercoagulability with increased procoagulation mechanism all result in early thrombus interaction with the endothelium and stimulation of local cytokine production, and causes leukocyte adhesion to the endothelium and promoting venous thrombosis. And it depends on the relative balance between the coagulation and thrombolytic pathways. Thrombus propagation occur. Physical examination and history. So symptoms may range from absence to a massive swelling and cyanosis with impending venous gangrene. And three patterns of thrombosis are usually recognized, like isolated calf vein distal, femoral-popliteal, and iliofemoral thrombosis. Symptoms tend to be more severe as thrombosis extends more proximally. And when present signs and symptoms of acute lower extremity like pain, edema, erythema, tenderness, fever, prominent superficial veins, as flux tend to go collaterally or to the veins that are not obstructed, pain with passive dorsiflexion of the foot, which is called Homan's sign, and peripheral cyanosis later. You see one of the pictures of deep vein thrombosis on the right side, phlegmasia cerulea dolens, which is characterized by triad-like massive swelling, cyanosis, and pain, and is the most severe form of acute lower extremity deep vein thrombosis. It usually results from complete thrombosis of an extremity's venous outflow. And in advanced cases, it is marked by severe venous hypertension, which is not usual for veins. As you know, their pressure is low, like from 5 to 25, depends on the location. And it can lead to venous gangrene. Venous gangrene is particularly associated with warfarin-mediated protein C depletion in patients with cancer or heparin-induced thrombocytopenia. Lymphedema, superficial venous thrombosis, and cellulitis should be excluded as the most common presenting symptoms with inconsistent sensitivity and specificity are calf pain and swelling. History of pain in 50% of patients, redness and swelling. And physical examination by the physician is accompanied with lymphedema, which may be unilateral or bilateral if the thrombus extends to pelvic veins, and red and hot skin with dilated veins and tenderness. And we have here a classification called CEAP, or Clinical Etiology Anatomy Pathophysiology, and which veins are considered deep ones. So deep veins, according to this classification, like inferior vena cava, common iliac, internal and external iliac, pelvic vein, including a gonadal artery and a big broad ligament veins, common femoral, deep femoral veins, femoral popliteal, and paired crural veins of anterior and posterior tibial and peroneal, and muscular veins of gastrocnemial and soleal. As per NICE, or National Institute for Clinical Excellence guidelines, following investigations are done. Of course, D-dimers, which are very sensitive but at the same time not very specific. D-dimers are sensitive for any coagulation process, of course, of thrombi formation. Coagulation profile should be done, and proximal leg vein ultrasound, which when it's positive, it indicates that the patient should be treated as having a deep vein thrombosis. The first step is to assess clinical probability of deep vein thrombosis using the Wells scoring system. And probability is low when patient scored from 0 to 1, and thus who have 2 or above scored, clinical probability is high. And you see this slide with some steps to do by measuring D-dimers and saw head. For example, if a patient scores a 2 or above, either a proximal leg vein ultrasound scan should be done within 4 hours, and if the result is negative, a D-dimer should be done. If imaging is not possible within 4 hours, the D-dimers test should be undertaken, and interim 24-hour dose of a parenteral anticoagulation should be given. A proximal vein ultrasound scan should be carried out within 24 hours of being requested. In the case of a positive D-dimers test and a negative proximal leg vein ultrasound scan, the proximal leg vein ultrasound scan should be repeated 6 to 8 days later for all patients. If the patient does not score 2 or more on the Wells score, but the D-dimers test is positive, the patient should have a proximal leg vein ultrasound scan. So D-dimers and ultrasound scan should be done for every patient that is suspected for deep vein thrombosis. Of course, you have to make a differential diagnosis to exclude other pathologies, and it should be done with the following, like cellulitis, post-thrombotic syndrome, especially venous eczema and lipodermatosclerosis, a ruptured Baker cyst, which is located posteriorly between gastrocnemial muscles or muscle, a trima, superficial thrombophlebitis, peripheral edema, heart failure, cirrhosis, nephrotic syndrome. All of them can produce in an outdated or decompensated state of venous or lymphatic obstruction, arteriovenous fistula, which increase preload of the veins, and congenital vascular abnormalities, and of course vasculitis, which is directly inflammation of the vessels. A prognosis: many deep vein thrombosis will resolve spontaneously with no complications. However, post-thrombotic syndrome occurs in 43 patients or 2 years post-DVT. The risk of recurrence is high, is up to 25%, and death occurs in approximately 6% of deep vein thrombosis cases. Early mortality after venous thromboembolism is strongly associated with the presentation of pulmonary embolism, advanced age, cancer, and underlying cardiovascular disease. So, to be clear, nobody will die from deep vein thrombosis, but will die from migration of the thrombi from deep veins of the legs, most common, to the lung, and will make pulmonary embolism. Treatments: the cornerstone of treatment is anticoagulation and should be addressed accordingly to the underlying causality of deep vein thrombosis. So, preferred anticoagulation in cancer-associated thromboembolism is low molecular weight heparin and factor 10A inhibitors, including rivaroxaban. However, in the following circumstances, the higher level of anticoagulation should be considered. In patients with recent diagnosed cancer, extensive vein thrombosis embolies, circumstances, cancer treatment-related adverse effects, including vomiting. In circumstances where one daily oral therapy is the preferred management, the following options are viable, like rivaroxaban, edoxaban, and vitamin K antagonists like warfarin. Deep vein thrombosis in the context of liver disease should be managed with low molecular weight heparins. Direct oral anticoagulants are contraindicated in raised INR or international normalized ratio levels. In patients with renal disease, a suppressed creatinine clearance to less than 30 ml per minute, vitamin K antagonists are recommended. Low molecular weight heparins should be avoided in patients with end-stage renal disease. In patients with remarkable past medical history or of coronary artery disease, the following alternatives are recommended, like vitamin K antagonists, like warfarin. Another one could be rivaroxaban, apixaban, or edoxaban. In patients with remarkable dyspepsia or a history suggestive of gastrointestinal bleeding, vitamin K antagonists and apixaban are the preferred treatments. In the group of patients with a history compatible with poor compliance, vitamin K antagonists are preferred. However, it should be noted that still some patients might be highly compliant with other alternatives. Since most anticoagulants have the potential to cross the placenta, the preferred anticoagulation therapy during pregnancy, very important, is low molecular weight heparins. Duration of treatment, for example, low molecular weight heparin or fondaparinux for 5 days or until INR is greater than 2 for 24 hours. Unfractionated heparin for patients with renal impairment and increased risk of bleeding. Vitamin K antagonists for 3 months. In patients with cancer, consider anticoagulation for 6 months with low molecular weight heparins. In patients with unprovoked DVT, consider vitamin K antagonists beyond 3 months. Rivaroxaban is an oral anticoagulant, which is factor 10A inhibitor, which has recently been approved by FDA and NICE, and is attractive because there is no need for regular INR monitoring. If platelet count drops to less than 75,000, switch from heparin to fondaparinux, which is not associated with heparin-induced thrombocytopenia or HIT. Thrombolysis or thrombolysis. The indication for the use includes symptomatic iliofemoral DVT, symptoms of less than 14 days duration, good functional status, a life expectancy of 1 year or more, low risk of bleeding. The use of thrombolytic therapy can result in an intracranial bleed, and hence careful patient selection is vital. Recently, endovascular interventions like catheter-directed extraction, stenting, or mechanical thrombectomy have been tried with moderate success. Compression, Hasseri, or below knee graduated compression stocking with an ankle pressure greater than 23 millimeters of mercury for 2 years is if there are no contraindications. And these stockings with compression are not too usual and not too easily to stay with them and use them often. Inferior vena cava filters if anticoagulation is contraindicated and there is a recurring or apparently repeated deep vein thrombosis with even pulmonary emboli, small or diffuse. Newer drugs like rivaroxaban, apixaban, dabigatran, edoxaban, and betrixaban are relatively newer factor Xa inhibitors and approved for prophylaxis of DVT. The duration of DVT treatment is 3 to 6 months, but recurrent episodes may require at least 12 months of treatment. Patients with cancer need long-term treatment. Thank you for your attention and hope this video is really useful for you. Maybe not too much pictures, but information is actual and can be used in your practice. Thank you very much and have a great time.